Hello and welcome back to the I Rehab podcast. My name is Nick Kane. Today we're talking with Paolo Perna. Paolo Perna is a pathway development physiotherapist at the Chelsea Football Club and also doing his PhD on hamstring injuries and return to play. We focused our conversation today a little bit around the criteria-based aspect of rehab and how we can target our testing throughout the progressions of rehab to guide us, and also the return to play aspect of the more back-end components of the rehabilitation around decision-making and the communication, and all things that go with that around preparing the athlete for performance. There is a couple of articles we'll put in the show notes. Apollo's recent publication for Res Sports Med, which is full access, return to play criteria following a hamstring injury in professional football, a scoping review. One of the co-authors there was Fergal Kieran, who is our recent podcast guest and has done a masterclass with us. Another great little paper from Polo is a blog article that was published on British Journal of Sports Medicine, One Size Does Not Fit All, Tailoring Hamstring Return to Play Assessments in Football. Now, event and masterclass updates, obviously hamstring topic. We have recently sold out the hamstring event in Italy. However, we have some great events coming up, which will touch around hamstring, which is in the I Rehab event in India with Dermot Simpson talking to hamstring rehab, and also Fast Track the Injured Runner in Boston. Brian Heiderscheit will talk to hamstring, amongst a couple of other top clinicians that will be adding to the lineup there. Masterclass-wise, obviously, you cannot go past. We've got Fergal Kieran coming up in a masterclass, as well as Nick Court, who talks a lot about the assessment throughout the rehab process. And obviously, Brian Heiderscheit's there. We've got a history of some masterclasses as well, of course, from the great Jordan Meneguccia. So plenty of great content there and past podcasts you can tap into for more hamstring resources. Hope you enjoy this chat, and we appreciate Paolo coming on. And yeah, please enjoy. All right, Paolo, welcome to the How I Rehab podcast.
Hello, Nick, and thanks for inviting me.
Mate, good to have you on. Those who may have read a little bit about some of your work and some work you've published and sort of written across different elements on the website that we can find around hamstring testing. Fill us in a little bit about where your interests come from within the hamstring space, and also tell us a little bit about yourself and your background and what you're doing now career-wise.
Yeah, sure. So I'm originally from Italy, from the south of Italy, and that's where I grew up and graduated in physiotherapy. And I spent the first few years after graduation in Italy, and I had an interest in sports and sport injuries. So did postgrad in sports physio, and then because I spent a semester in Spain while I was studying, I also did a course in osteopathy postgrad in Madrid. And then after that experience, I decided to move to the UK, where I have been living for the last 10 years. And in the UK is where I started working in professional sport, and in particular in professional academy football, soccer. And over that period of time, when I transitioned into sport and full-time role, I realized how our education as physios got gaps when you work in sport, especially all that performance aspect of the profession. So I did my master's in London in strength and conditioning because I wanted to sort of bridge that gap. And once I finished the MSc, I realized I had a genuine interest in research, and I really enjoyed my time doing my dissertation, collecting data, doing research. So I thought I wanted to continue down that path, and so in 2022, where I started my PhD at University of Suffolk, and the topic of my research is hamstring injuries, but in particular looking at return to play criteria in football. And I guess in terms of the clinical interest in hamstring and where it came from, I think obviously when you work in professional sport and when you work in team sport, you have to face very often soft tissue injuries, and in particular hamstring injuries. And that's not just my experience. If you look at the epidemiological data. We know the prevalence of hamstring injuries in football. And so when you expose and when you have to rehab those injuries, then you realize all the challenges that comes with them. And in particular, re-injury, the high re-injury rate of hamstring injuries. So if we look at the UEFA study, we know prevalence and the recurrence of hamstring injuries is around 18%. So it's quite a high re-injury rate. So this is obviously a big challenge for us, and this big challenge and can be tackled in two ways, really. So either looking at the way you're rehabbing hamstring injuries, or the way of your decision making around return to play. So we can either look at, okay, we have re-injuries and we have those challenges. So what are we doing in rehab to make sure that these athletes are ready to return to play? Or the other things to look at is, what's our decision making? How are we deciding that these athletes are ready to return to play? And what are the criteria? What are the objective markers that we're taking to make those decisions? And so these are the two phases of this problem. And then I think when I felt what I felt was my passion and my interest was more towards that decision making and that return to play criteria. So when I decided about the PhD, I thought I wanted to go down that route. And of course, you're not forgetting about the other one. And then obviously, throughout your research, you are going to work towards both of them. But definitely that was one thing. And then the other one is, when we look at return to play, is such a long and complex journey, and probably you have two ends of this spectrum, where at the beginning you have your injury and your diagnosis and you're very much medical aspect of return to play, but then at the end you have your return to training, your return to play, which is very much on the performance side of this spectrum. But then there are loads of like shades of gray in between. There are a lot of different aspects, and this transition from a more medical and more acute to a more performance part of the return to play. And I guess probably my PhD is more oriented towards that late stage and end stage of the rehabilitation. And in fact, my supervisor, my PhD supervisor, is Marco Beato, and his background is more as a sports scientist, more in terms more. His research has more been towards eccentric strength and high-speed running and return to play. So definitely, the interest of my PhD is more shifted towards that late stage and performance stage of return to play.
Okay, excellent. You've given a really nice summary there for us around, I guess, what the study is, and we'll highlight one of the blogs that you've written, which I alluded to in my intro. I think that was with BJSM, but we'll put that in there to provide some further context. So I thought, given what you've just said, that we sort of plan to sort of work our way through a case, for instance, of a hamstring, but we'll sort of focus more the predominant aspect around that late stage decision making and some of that late stage return to play, given that's your sort of key area of interest. But to sort of start things up, I guess, in the earlier phase and how it all comes together, can you give us a bit of an example of a case maybe in mind that you've dealt with in the past? And I guess how you shape around your decision making process there. So I guess you've seen an athlete, provide context of what that injury is. What's your initial thinking of that injury around the return to play process? What are some of the things you formulate in your mind or with the team? And then we'll work through some of the steps that come thereafter.
Yeah, sure. So let's start from this, and I think the diagnosis is the first thing, and is really important to have a clear diagnosis. So let's imagine that we have a proximal biceps femoris injury, and we're talking about a footballer. So now the diagnosis is the first part. So how important is the diagnosis, and how then knowing well the diagnosis will help shaping the return to play. So I think knowing very well where the area of the injury is, the type of injury that we have, and the mechanism of injury will then help us mapping out our return to play. So So the first thing is when we know that and we have all this information, then we can have a prognosis and we can have an idea of, okay, how long is going to take for this injury, how long is going to be the rehab, and obviously the area, but especially the type of injury will clearly give us an indication of where we're going to go with this. And I think you guys have been great in terms of sharing ideas around it and inviting people. We're talking a lot about this idea of location based or location specific rehabilitation. So that's the first step. And now we have to think about our return to play. So from the moment of the injury, how are we gonna get to the end stage? How are we gonna get to take this player back to play football? So now we have our idea. Okay, we've decided that we think this is gonna be X amount of time for this injury. Now we have an end date. So we have an end goal in mind. What we do is how do we create our return to play process based on this? So how do we take this player from point A to point B? And I think normally for me, the first thing is to start with the end in mind. Okay, we know that that's where we want to get to. So that's our return to play. Okay, now let's map out all the stages and how we're gonna get to the end. So I think the first thing is to think about the stages of the rehabilitation that we want to go through. And I think we can start by being like quite easy with one of the models that's been described in the literature that is very simple, but I think very effective. That is the what Matt Backthorpe described in his studies on field rehabilitation. So essentially what they did, and you find this figure in his paper, you have two circles. So you have the rehabilitation circle and then you have the performance circle, and they merge together in the middle where you have the on-field rehabilitation. So you have rehabilitation at the start, and within the rehabilitation circle we'll have our acute stage, we have our gym based and preparation for all the sport specific that is going to come later. And then you have on-field rehabilitation. So you have the preparation of those sports skill on field. And then you have the return to training, the return to play, and then you have the return to performance. So now you have already all your different stages. And the next thing is, okay, now I know the stages I want to go through. So I know the things that I want to do in order to return to play. The other part is, and that's where probably the interest of my PhD is, okay, in between those stages, what are the criteria that we use to progress from one to another? And and as you said, so the first part of my PhD was looking at return to play criteria for hamstring injuries. So return to play now is a big definition. So how do we define clearly return to play? And I don't know, Nick, if you've had this experience as well, but sometimes you speak to people about return to play, and then you suddenly realize that what they mean by return to play is not exactly what you exactly meaning by return to play. And that's not for hamstring injury, for any type of injury, where you say, okay, what we think about return to play. And then for someone, return to play might mean, okay, they're returning into full training, unrestricted training, they have no modifications, and that could be what their definition is. Mine might be when they've returned to play, or when they're available to play, or when they are playing now 90 minutes of football. So having a clear definition of return to play is also very important. So and if we think about that definition, then we start thinking about also the stages to get to that. And very often the stages are also dictated by the type of injury. So if we think about hamstring injury, for example, that on-field rehabilitation, so everything that we do on pitch to prepare those players, will also have some specific milestones or things that we want to achieve in order to make sure that these athletes are ready. And in particular with hamstring injury, we're going to have obviously return to high-speed running as a big component of this phase of rehabilitation. And then we can talk later about high-speed running and return to high-speed running, because that's also another interesting part, and that's probably something that we realized while we were studying and during everything that we did with our scoping review we published last year, where we looked at return to play criteria, and we soon realized that a lot of people talk about return to play, but there is very little research on actually what you do in preparation for that. So we talk a lot about return to play criteria, but what about return to high speed running? What about return to training? So these are phases that are earlier than our return to play. So do we use the same criteria for all these phases? Are the criteria going to change between what we do for return to high speed running or what we do for return to play? So this was one of the big questions, and probably some of the follow-up work that we're doing is based on this. And one thing as well is, so once you've mapped out your stages, once you've mapped out all your criteria, and now you can think about the content of the rehabilitation for each of these stages. So if I know that I'm gonna prepare this player, and I know that the criteria for return to high speed running are clinical strength, or what type of strength. Let's think about eccentric strength in preparation for sprinting. Then now I can think about the content. So in this rehabilitation phase, well, I know at the end of this rehabilitation phase, I'm going to test this athlete for his eccentric strength. What am I going to do during this phase to prepare for that? So how am I sure that I'm doing a nice progression of exercises? Am I progressing and periodize my strength to make sure that when it's time to return to high speed running, I've actually managed to reach those goals that I had in mind, and I'm ready to transition to the next phase.
Okay. Right, a really nice take through of obviously the overarching aspect. I'm going to break down a couple of things there if we can. Obviously, at the start, you've talked around the local area, the area of the injury, the tissue type, and the mechanism. I think that sort of speaks for itself. I was going to touch more on the mechanism, but obviously, we need to rehab towards what type of mechanism of injury that was. But you've spoken there to the criteria of the different stages. And I just want to break that down a little bit more and provide some examples of what some of that criteria might be in the stages. And I know, as an example, you might use the 90-20 test or a claw test or an ISO hip or knee extent flexion test. Can you give us an example of a couple of different objective testing methods you would use and where they sit in that cycle, as in, when it needs to be cleared so you can move to the next stage that may include sprinting?
Yeah. Okay. So the first thing is, so let's talk about what I said earlier about. So I'll give you these two things as a context, and then I'll answer your question. So the first thing is, we said about, okay, how the criteria are gonna change, how they change between the different stages. So one of the things that we found with our scoping review when we looked at return to play criteria is that we have a huge variety of criteria available. And rightly so, you mentioned strength. Strength was one of them. So because of these difference, we divided the criteria in three different categories. So we had clinical criteria, which were our absence of pain, muscle flexibility, imaging, medical opinion, and then we had a lot of the described criteria were strength, so around that strength capacity. And then we had our performance, which was more field-based, more GPS type of test. So now we have these three categories, and that's the way I like to think about criteria. So we have these three categories of tests, and that we can use throughout the rehabilitation. Now, when do we use them? Between stages. So a very nice description of this sort of approach is in there's a Delphi study, the Dunlop and colleagues 2020, and what they did was they asked the experts to rate the importance of. They gave them a list of 7 or 8 criteria, And then they ask them to rate the importance of those criteria in different phases. So they said, okay, now you have these 8 criteria. Which one are the 3 most important out of this list for return to high speed running, for return to training, for return to play, and for return to performance? And then the interesting thing is that the way it changed is in the earlier phase, so in the return to high speed running, people felt that, so the experts felt that it was more important to use clinical and strength markers than performance. And then as you went more towards return to performance, actually the clinical were less important and the performance became more important. And that makes absolute sense. So if we are returning now, so if we are in the on-field stage and we are returning to high-speed running, obviously doing a peak speed test or doing a repeat sprintability test or check that your GPS data are aligned with your match, it was probably not relevant at this stage. But actually knowing that the player hasn't got any pain, that he's got full range of movement, that he's got good strength, is probably quite relevant at this stage. But then once we go ahead, so when we are now returning to play or returning to performance, probably now we know already that there's no pain. So knowing about the pain is probably not as important at that stage, but actually knowing that they can run a peak speed, that they had a good exposure to load on pitch, they can do it repeatedly with a repeated sprintability test. So these are things that now matter a lot more in those phases rather than the return to high speed running. So this is just to give you a little bit of background of maybe the way you can look at things and the way I think. And now out of these 3 categories, let's talk about strength. And as you said, strength is a big one. So the capacity of the muscle. So how are we gonna test it? And then you mentioned potentially some of the tests, like the hip ISO, the knee flexion, or the 90-20. Now, one of the thing is when we talk about rehabilitation and exercise selection, one of the things that we do is that we go into the literature and we look at, okay, what type of hamstring, which one of the hamstring is more activated by by the exercises. So this is one, again, when we think about that diagnosis and the importance of knowing where the injury is, if it is a injury to the semimem, or if it is an injury to the semitendon or the bicep femoris, the long head of the bicep femoris, how can we be specific when we prescribe exercise for that particular muscle? So a lot of the research that has been done was around exercise selection because of that. And it started with all the work that's been done in Australia by the Bourne and David Opper group, where they looked at with EMG or at the activation of muscles. And there are other studies, and you had Stephanie Lazarchuk on the podcast as well, and talking with her study as well about the activation of different muscles. So the issue is all these principles are for exercise, but not for criteria. So we know a lot in terms of exercise activation. So now we have to, I think, take those principles for our testing as well. So if we know that normally, if we divide obviously the exercises and the type of activation of the hamstring in either hip dominant with the hip extension or knee dominant with the knee flexion, and we know from the literature that the knee dominant exercise activate more the medial hamstring, and the hip dominant activate more the bicep femoris, particularly long head of biceps. Now, when we are deciding what test we want to select, we have to take that into account. So, as you said, for example, and if we go back to the example we are talking about, so this proximal bicep femoris long head injury, in that case, obviously throughout the rehab, we might use a knee dominant or a knee flexion test, especially in the early stages, to see how this muscle is responding to load. But if we want to be really specific, so we're probably gonna look at a more hip dominant test, like a run specific hip ISO. because we feel that's is more relevant in terms of the activation of that particular muscle. And if with strength criteria and with strength test, essentially what we want to know is if this muscle is able to produce forces and is able to work in those particular movements and in those particular ranges. So obviously, if we are specific, we can probably get more information. The other test that you mentioned is, for example, the 90-20 test. So the 90-20 was actually described firstly in 2019, the Martin Lowry study, and in that case was used more as a neuromuscular fatigue test. So just to see whether the muscles had recovered. And then, obviously, because it was described and it was reliable, then we started using it in return to play as well. And if we look at the 90-20, there's actually another nice study from 2020, the Moreno Perez. In that study, what they did, and it's quite interesting. So they I try to correlate an eccentric exercise like the Nordics with two different isometric tests, so the NEAT 15 and the 90-20. And what happened is that actually there was no correlation, so they cannot be used interchangeably. So if you're using eccentric, you're using eccentric. If you use 90-20, you use the 90-20. But again, it showed reliability, the 90-20 as a test. So now, if you think specifically at the 90-20, I'm not sure how many people are familiar with the test. So you're standing and you have your hip at 90 degrees, knee at 20 degrees, and you push down on force plate. So with this particular test, you are in a very functional position and in a different position. And then we can talk about, for example, how the selection of these strength tests can be influenced by the mechanism of injury as well. But the 90-20 is a reliable test, and it is a test that I like. Probably from experience, I would say that the standardizing the test and repeating the test is probably the challenge, because there are a lot of compensatory movement that can happen, and sometimes probably my suggestion would be to practice the 90-20 during rehab, and just make sure that the athletes are used to that type of movement before going into testing, because sometimes you then go straight into testing, and that might be a bit challenging to find the right position, and might not be as reliable. So that's probably one of the main things I would suggest on that.
Okay. Good. So I guess coming off there, the main thing is, let's say if I just doing one test, so for the injury, your reference there around more of a proximal biceps injury, doing a prone iso curl probably isn't giving me all the information I need to be able to test that tissue out. And your preference in around testing for more that proximal tissue, you would say the iso sort of hip push might be your preferred test that you would utilize. Is that fair to say over maybe a couple of the other examples there?
Yeah, I would say definitely more like a hip dominant. So if the choice is between the knee flexion or the hip dominant test, the hip iso, I would definitely go more for the hip iso. If I had to choose one test, definitely I think a hip dominant test will give me more useful information in this particular case.
Okay. And I guess we're still sort of talking around, I like how you broke it down to three different parts around the clinical range of motion, palpation, etc., into strength and then field. So we're still just on the strength phase now. And to sort of wrap that up, we'll move into the field area shortly. But do you place much emphasis when you're doing the test at the hip iso? Are you purely looking at rate of force? Are you purely looking at the force and strength output? Or are you also looking at some of the rate of force development? And how does that inform your practice or influence what you're doing?
Yeah. I think rate of force development is definitely one of the things that I would look at as well. If we look from a literature point of view, probably RFD is not as described, and a lot of the research around strength look more peak force in terms of what we look at. Probably from our scoping review, there was only two papers that looked at rate of force development, and those were the two case studies from Matt Taberner. So they used in that case the 90-90 test on the force plate, and they also analyze rate of force development 100 millisecond as the way of testing the rate of force development. I think it plays an important role, especially when we're thinking about that return to high speed running and that idea of for the hamstring to activate very quickly. So it makes sense. It makes total sense to test rate of force development. And I think probably the fact that it was present only in case studies and not in other research is telling us that this is one of the things that we feel as practitioners or people that work on the field, there is something relevant. And we are doing it, and it's interesting to know that other people are doing it, but there's not a lot of research to support that. And again, probably for RFD, the same very similar suggestion to the 90-20, I think is also something that I would work on throughout the rehabilitation before testing. I think for RFD, the queuing of the test it becomes really important compared to peak force. So it's important if you have athletes who've not used to it or you've not done this test before. It's really important to prepare towards the test before doing it, and the queuing from us is key, I think.
Yep. Yeah, certainly. Obviously, the queuing seems to be something that's mentioned a bit around that testing because it can obviously change, I guess, your outcome so much. All right, we're going to if you can give us like almost like a dot point answer into your criteria to return to high speed running or max. Let's call it above 85%, so close to maximal speed running and there above. What do you need to see in that sort of clinical circle, the mid circle around strength output? And you mentioned eccentric strength earlier. What are you using, and what's important to use as a clearance to return to sprinting in that space?
Yeah, sure. So first of all, I'll give you a little bit of background on high speed running, and then I'll go into the answer. I think it's really important this because again, same as before, that's one of the things that you start thinking about when you talk about return to play. What the idea of what people have about the definition of return to play might be different. For high speed running, again, is the same thing. So when we say returning to high speed running, and you mentioned rightly so 85%, and we get to that, what are we actually talking about? So what speeds are we talking about in terms of return to that particular phase? And I said rightly, you talk about 85% because when we look at hamstring injuries, and we look at some of the studies in particular, there's one study that is really interesting on the speeds at which the hamstring injuries happen. Is the Francesco Aiello's paper and colleagues in 2023. So basically, what they did in this study was to basically looked at the videos of soft tissue injuries in football, and they correlated the exact moment when the injury happened with GPS data. So they looked at the GPS, or what was happening from a GPS, from a speed point of view during the exact moment when the injury happened. And they did it for different soft tissue injuries. They did it for quads, they did it for adductors, calf, and hamstring. And while the other three, so while quad, adductors, calf, they happened at different speeds, there was a common pattern for the hamstring injuries. So all these hamstring injuries, they all happen above 80%, and they happen above 25 kilometers an hour. So now, when we think about return to high speed running, we probably know that the risk lies into those kind of ranges and those kind of speeds. So when we say about return to high speed running, and if we go off purely the definition of it, and we go about what the definitions are, very often the high speed running is defined as above 20, 21 kilometers an hour in football, and then sprint is above 24, 25. So we need to be careful as well when we talk about return to high speed running, because we might think, okay, we are above 20, 21, and that's okay. But actually, majority of the injuries happen later on in that 25 plus 80%. So as you said, the question around the strength criteria for before returning to sprinting. I think as you said, is we test different things. So we test capacity, we test isometric, we test eccentric strength. And in particular, because of the importance of the eccentric contraction during sprinting, I think it becomes very important to test eccentric strength before returning to high speed running. So the preparation of that, so with the exercise throughout the rehabilitation in that phase, in that circle, rehabilitation circle, and now the testing of eccentric strength. The problem is that we have with testing eccentric strength is that at the moment we have two ways of doing it. One is with Nordics, so NordBord testing, and the other one is with the isokinetic testing. So these are the only two ways of testing eccentric strength. And on both of them, if we look at the literature, there is reliability of those type of tests. The NordBord is widely used in football. There are also some different studies that are giving some normative data, but equally, what we know is that some of the studies that we have, like the Timmins study, they tell us that okay, above, let's say, for example, 337 newtons, then you more likely not to have injury. But then actually we know that correlation doesn't really happen in real life. We also have, there's also another thing to mention when we look at NordBord and Nordics eccentric strength. That sometimes some of the study talk about absolute values, like the Timmins study, or that's the Bishop study, where they validate the NordBord testing in football, and they give us some absolute value. But we actually know that there's a very high correlation between these values and body weight. And we know that from the Boucher paper in 2018. So actually, when we look at these results, we always have to look, I think, more from a body weight perspective, newtons to body weight, rather than just pure and absolute peak. And that's for NordBord testing. And the other one is the IKD testing that we can use as an eccentric measure of strength. Now, the IKD is an interesting one because it is very, very used, validated, reliable test. But for example, in our scoping review, the IKD was mentioned in only one study, and that study said that it's useless for return to play after hamstring injuries. But let's take a little bit more of a look at these results. So this was a study in 2014 from Johan Toll, and what they did was they did a rehab period, and then they tested IKD at the moment of return to play. Actually, majority of the athletes that they test had a discrepancy, a significant discrepancy in terms of strength between uninjured and injured limb. But they didn't consider that, and they said, okay, because you've completed your rehabilitation protocol, you return to play anyway. And then they did a follow-up later on, and they saw that actually the fact that they had a discrepancy and a asymmetry in terms of strength didn't really matter with the re-injury later on. So they concluded, okay, well, probably it's not very useful to know that, because if they didn't get a re-injury later, then we might not test IKD. I think I would still use it, and I still do use it in practice. I think is a useful tool for both concentric and eccentric strength. In terms of the speeds that you use, I think if we look at the literature, probably there's a combination of both slow speed, so 60 degrees per second, to a faster speed around 180 to 140 degrees per second.
And if I said, you mentioned body weight, what's your body weight target, ideal body weight target for a Nordic, and what's your ideal body weight target for a concentric and an eccentric aspect on the IKD?
So for Nordics, I would say around 5 times body weight for the Nordics, and around 2 times body weight for the IKD.
And then obviously you mentioned at the start of the podcast, the other areas around that return to play aspect. We've defined what return to play is. So let's, for the sake of argument here, call it, the players back to playing match minutes. What I guess are a couple of challenges, even if you can provide us 1 to 2 difficulties that come with that late stage element around return to play. And I know in football there, you've got all the congested training schedules and matches and the ability to get everything in, on a week-to-week cycle there when they are playing twice a week. But yeah, that's just me from the outside looking how things would be really tough to manage that at times. What are the key things around that decision-making process that you found in both your review and practice?
Yeah. So I think there's two elements to it. I think especially what you mentioned, the match and the fixture congestion comes more into probably a later phase, that return to performance phase. But if we talk about availability for match minutes, so return to play and match minutes, I think probably there's two things that I find challenging. The first one is that progression of high speed running. So how do we periodize? How do we progress the high speed running through the late stage? And unfortunately, when we look into the research, there's little help that we have. There are some nice frameworks, the ones that mainly use, like Matt Taberner's or Matt Backtorp's ideas around return to play. But one of the challenges is these are still opinion papers, and they're really nice and very nice to use in practice. Very well done. That's why they used. But there's still not like very strong evidence around this. So how do we progress? Two things. First, the speed. So how quickly do we go through those stages, and how quickly do we get to those speeds and those more at-risk speed above 85%? And the other thing is, how do we monitor and how do we manage that total load of high-speed running per week? So in all our microcycles, how do we go from this volume to the next volume? And obviously, this is very much dependent on the injury. It's really hard to say, okay, these are your guidelines, or you should go up, I don't know, 10% or 20% per week. I think is really difficult to do, but definitely one thing is for me to look at what the general total load is for the week for that particular athlete, and then try to target different percentages of that load throughout the weeks, and also take in consideration what their outputs are for on a match day, and try to prepare them for those type of outputs throughout the rehab. That's one of the challenges. So the exposure and the volume of high speed running during that on field phase. The second one is okay. We know that we have to expose player to sprint. So let's say we've passed that phase of return to high speed running. We're comfortable that they can run at those high speeds, so above 85%. Then now the question is, okay, how are we going to do it week by week? How many times we're going to do it? So I think we know the importance of exposing, and I think twice per week these players to sprinting. How far between them we're going to do that? So one thing is, I think we look at the data and the research. We know now there's enough evidence that kind of 48, 72 hours are needed. More 72 hours are needed for the hamstring to recover from high intensity work. So, for example, if we have done some sprinting on one day, then probably I would wait at least 72 hours before we expose again that player to sprinting. So, and then it's up to us how we manage that into our microcycle of, let's say, 6 days that we're working with that athlete, and how we program the days when these things happen. So that's really important, and that's a big challenge for me. And the other one, probably the other big challenge is it seems like, okay, we have the rehabilitation phase, we have the gym phase, we do so much from a gym perspective, and then we go on field, and then we kind of almost forget about all the strength work that we've done before. But actually, the strength and the on field are still going together. And for me, one of the big challenges is how do we manage that volume between the two? So as we ramp up the volume on pitch, how do we maintain some good strength? Like what strategies we use? Are we going to be able to load as much as we were doing before, or do we have to change and adjust the volume of those sessions? And probably we will have to, because of the fatigue element, because then the fatigue element becomes a risk factor for those hamstring injuries. So we have to be able to then decrease that volume of strength, but still be able to hit some of these big eccentric sessions. And also, what other strategies can we use to load the hamstring? So for example, in my case, in the isometric strength then becomes really important in those type of scenarios where they're not going to give you as much soreness, but you can still load the hamstring, especially in tendon injuries. Like really important to load that with that isometric component, and maybe like to do it and to use it also in preparation for those big sessions and big sprinting sessions.
Yeah, very nice. And I think you brought that together really well. It's certainly a challenge around that balance between obviously the gym and sprint load and then return to play whilst trying to maintain. I guess a lot of the time it's a case by case basis. Your the final piece of that around the return to play there, that you've sort of looked at from your studies and experiences. Is there anything I've sort of missed in what I've tried to communicate through this line of questioning that you think is really important to pass on? That's one of the the foundations around the return to play piece. Is there something we've missed about chatting to here?
Yeah, I think when we looked at the with the scoping review, one of the main things is that actually we realized that it's still a very young sort of area of research. So there's still a lot that can be done, and one of the aims of the scoping review was to actually identify some gaps and identify some lines of research. So I think definitely, as I said before, the clear definition of return to play criteria and stages, and also definition of which criteria we use for each different phase. And I think the other challenge is for me, we talk a lot, and in research there's a lot of talk about hamstring injuries in general, but actually not all hamstring injuries are the same. So can we really be specific, and are we going to get to a point where we're going to know that for that particular injury, these are the most appropriate tests. That particular injury, these are the most appropriate tests. So rather than talk all the time about hamstring injuries in general and give just very non-specific guidelines and non-specific tests for hamstring, we're going to get to the point where we're actually going to research on that particular injury and be really specific in the way we prescribe exercise, but also in the way we look at testing. And can we also incorporate in that decision other factors like the type of injury, like the mechanism of injury? So can we actually look at these things and from these things make an impact on the type of test that we're going to choose?
Yeah, good. Yeah, and there's certainly some of my sort of takeaways from that around being really targeted when it comes to what type of muscle in the area when it flows onto both our testing and the exercise prescription and then on the field. I'll finish with one question, and that was how I mentioned at the start around mechanism of injury. And let's say, for instance, this athlete we've talked around did their proximal biceps injury, like bending over to stretch, like a stretch type mechanism, when they were sort of running at a decent pace, bent over to kick a ball or pick a ball up. Let's say it's in rugby, and they felt their hamstring, rather than just they weren't just like running in a linear speed. How can that change our back end part of our rehab for you? Like obviously, are you still targeting the sprint exposure just as much, and how maybe are you bleeding that mechanism into your rehabilitation?
Yeah, no, that's it's a very good question. I think yes, absolutely. Like, I mean, we're still rehabbing the hamstring injuries like we would rehab a hamstring injury. So I don't think the mechanism will change the principles of our rehabilitation. So I think the fact there was a stretching mechanism doesn't mean that everything that we said earlier about high speed running and sprinting exposure and the importance of testing for sprinting exposure are now not relevant. They're still very relevant. We're still talking about hamstring injury, and the activation principles of that muscle and the type of work of that muscle will go through during sprinting, it doesn't change. So that part still remains the same. So for me, looking at mechanism of injury is okay. We know that there are loads of factors, and the mechanism might just be the last piece, but I think it makes sense to look at what the mechanism was and then really try and target again with exercise and perhaps with testing. And that's one of our potential questions. So how can we be specific as well in those positions where we load this player? So let's think about you mentioned that stretching mechanism with trunk flexion. So I think for me, during the rehabilitation, part of what I would do is to try and load that player in those particular ranges and try and see whether then those ranges are comfortable, that you can return to produce forces in those type of ranges. So I think on top of everything and on top of all the other things that we're still going to do because of his hamstring injury rehabilitation, can we also try and incorporate things based on the mechanism of injury? So that's the way I look at mechanism of injury as, okay, we know that the injuries happen in this particular with this particular mechanism. How can we be specific as well in the type of exercise that we prescribe throughout the rehabilitation to try and target as well that particular range? And that's from an exercise point of view. And then the question comes from a criteria point of view. So then if that was the mechanism of injury, and the question might be, would you then start testing him with that trunk flexion as well to try and see whether he can produce force in that particular position? I don't think we have an answer, and definitely not in the research, but I think it's a nice concept to try and think about.
Beautiful, mate, Paolo. Well, thanks very much for jumping on the podcast. It's been really great to have a chat. If people wanted to sort of touch base with you, what's probably the best medium they can do that through?
Yeah, probably LinkedIn with my name or Instagram with at Paolo Physio.
Cool, mate. Well, yeah, mate, we've really appreciated having you on. Enjoy reading about some of the work you're doing, and when can we expect a little bit more? Have you got some things in the pipeline that we expect to sort of be coming out and published soon?
Yeah, we have some work under review at the moment. So hopefully now is a bit slow with the review process, but hopefully in the coming months.
Beautiful. Well, we look forward to it, and yeah, thanks for joining us.